really good contribution that you guys gave to the journal the other month. Next, we're going to hear from Joe Chikwe, who's going to talk to us about dealing with bileaflet prolapse.
Is there a clicker? Or do I just tap?
There is a clicker.
Somebody steal the clicker.
You didn't walk off with a clicker, did you, Amy?
While we're trying to find the clicker, thank you all so much for giving up 2 busy days in your schedule to come to this meeting. It's an absolutely phenomenal turnout, and I really hope, oh yes, that's really well hidden, that you feel the trip was worth it. The program committee put, as you can tell, an absolute ton of thought into the content. I was asked to talk about bileaflet prolapse, so what I'm going to cover in about 4 cases is a resection technique, a caudal reconstruction technique, and then something that's not really quite either one of those. For just the range of bileaflet prolapse that you see, starting with the triangular resection of the anterior leaflet, which, as you all know, is a much more conservative approach, and then a sliding plasty of the anterolateral commissure, which is featured in this case, which was bileaflet prolapse. You've got a little bit of mitral annular dysfunction, a fairly voluminous anterior leaflet. It's pretty tall. Unusually, you don't have that area of calcification in the P1 area. You've got a slightly tall P2, fairly tall P3. It's obviously longer than that 22 millimeters that Dr. McCarthy described. And then this fairly voluminous anterior leaflet with this area of calcification unusually at the posterior medial commissure, and that area of restriction there, and this tall anterior leaflet comes well below the annulus. And I think you could convince yourself to ignore that calcium and leave it and just sort of close that indentation that's kind of quite restricted between the anterior leaflet and that commissure. But I think in the effort of preserving a little bit of mobility, it's, in this case, worth taking out the calcium, particularly in the younger patient. And then I'm going to essentially leave that and move to the anterior leaflet. So this is a very limited triangular resection. Obviously, there are a number of ways to address this with caudal reconstruction, but here that area of extra volume and poor support was limited to less than about a quarter of the free edge of the anterior leaflet. And if you can keep the resection to a very small amount, that will work well, and we'll come back to that. So here I'm just advancing that P3 segment up round past that area where we've made that defect, hoping that that's going to preserve mobility of that segment and therefore take the tension off the rest of the repair. I'm going to close this indentation. I don't normally close indentations. I'm fascinated that Dr. McCarthy does, and I've seen quite a few repairs where all of the posterior leaflet indentations were closed. I tend to worry that's going to leave a sort of curtain of material beneath the valve, but equally, I think the very impressive long-term results of the people that have shown that approach really is a testament to maybe doing that more. So there I've closed that indentation, and here I'm trying to imbricate my triangular resection of the anterior leaflet there. Ideally, the knot will be underneath because I know that that's going to be sort of continuously abrading my coaptation area of the posterior leaflet. And then I felt that this was a little bit voluminous, so I'm doing a triangular resection, which is obviously for the posterior leaflet much more aggressive than for the anterior leaflet. And here I'm preserving chords which I thought were normal heights in case I need them to address residual prolapse of my anterior leaflet. Then this is just a completely standard closure of a triangular resection. I try and imbricate the edges, certainly the leading edge within the coaptation zone. I don't bury the knots. I haven't quite figured out how to do that with this approach, but certainly I try and keep a smooth edge to really minimize the ridges and really eliminate those sort of tiny little jets of residual mitral regurg you get if you tend to sort of aggressively evert that. So it's just really nice and smooth all the way down to the base. It's going to be a true-sized annuloplasty. I usually use a flexible band. I'm very interested in this sort of mismatch between the voodoo of sizing to the trigones, which I do. It's now voodoo. I thought it was gospel. I learned something today, and then there's a saline test with a reasonably low line. It's much more mobile, that commissure, than I think it would have been if I hadn't taken the calcium out, and that's the post-bypass T with no gradient and no mitral regurg. So going from resection techniques to caudal techniques, this posterior leaflet transposition technique was something that I got interested in again after seeing Pat McCarthy's presentation at ATS 2 or 3 years back, but you can do it without that quadrangular resection and therefore without that vertical annuloplasty. So here's a patient again with a moderate degree of bileaflet prolapse. It's a fairly prominent anterior leaflet, fairly significant P3 segment, but there are some normal height chords there, and that's really makes you feel great when you see that, because I know I'm going to be able to take those chords and flip them to the anterior leaflet. Why do I like doing that? Because it sets the height. If I can find normal chords, it's very, very easy to then put them there. You can support them with Gore-Tex, but you've basically already sort of determined the height. Would I do just a caudal flip without the Gore-Tex? No. Sometimes I think when you look in the ventricle and you actually look at the quality of the chords, they're really flimsy sometimes. They're not, so if you look at those, they're okay, but those are, I think, quite a lot to rely on. So basically, those are going to go to the anterior leaflet. It's a very straightforward over and over figure of 8. It's a 5/0. We use cardia needle simply because it's got less memory than a proline, so it's very, very easy to work with the short length of it and tie it efficiently. And again, reading that a lot of people, particularly Tirone David wrote it in his wonderful textbook, really tries to bury the knots on the sort of ventricular side rather than the atrial side. That's something that when you look at this, you can intuitively see that that's worth trying to do. Then, it's a very standard approach to placing Gore-Tex. It's a 4/0 Gore-Tex through the fibrous head of the posterior medial papillary muscle, and that's going into the sort of coaptation zone within about 5 millimeters of the leaflet edge. Again, it's an over and over. The height of the Gore-Tex is just set by making sure that the Gore-Tex is straight as I pull the margin of the posterior leaflet, of the anterior leaflet, just down to the posterior annulus. And then over and over the leaflet edge a couple of times, and that's just tied. And again, it would probably take 2 or 3 of those Gore-Tex cords to support that bulky anterior leaflet. Could you have done a triangular section to that? Potentially, but I think that was a fairly broad area that wasn't supported, so it's less suited to a resection technique. It's more suited to a caudal reconstruction technique. And I think it really just goes to emphasize there's a number of approaches that you can use to treat lesions, and it's just a lesion-specific approach. That's a fairly reasonable saline test. It would be nice if the coaptation was a bit lower, but reasonable result on the post-bypass echo. Then this is a technique that every time I go to the conclave and hear Gilles Dreyfus talk about, I feel tempted by, and then I usually listen to my wise voice inside and don't do it. But in this case, there's a central jet in bileaflet prolapse, so it's kind of a balanced prolapse, and you've just got this sort of diffusely voluminous leaflets. The posterior leaflet is tall, the closure line is quite anterior. I'm sort of poking around trying to find specific area that's going to be amenable to resection or somewhere where I want to put cords, but I wasn't entirely convinced. So I thought it might be quite a good opportunity to try a papillary muscle sliding plasty. So I'm placing Gore-Tex with a pledget in this case. Carpenter advocates against using a pledget, but I'm using a pledget to really try and bring that posterior medial papillary muscle down towards that intermediate papillary muscle that's really adherent to the ventricular wall there, with a view that that might reduce the height of the P3 segment and the P2 segment without needing to do a number of cords and without needing to do a resection there. So that's just really bringing that down and tying it down the ventricle. And the idea is that when you've got a diffuse area of a prolapse and you can identify a papillary head that supplies them all, that might be nice. Now, I was extremely dissatisfied with this closure line. It's too anterior. So I put a number of cords in to try and bring it more posteriorly, but it made it much more regurgitant. So I thought, well, let's just take the clamp off and see how it looks. It did not look great. No MR, but horrible SAM. So obviously, I went back, and with cords to the posterior leaflet, we put 2 more cords to the posterior leaflet, 1 more cord to the anterior leaflet. That was the result of that, but I don't think the sliding plasty actually worked very well. And then finally, here's a example of a patient that had, I think, an outcome. This is 3 clips. This is, I think, a year out. Had residual mild MR, but a year out had severe mitral regurgitation. As you can see, has got 3 clips, and this is the middle one that I'm trying to pull out. There's one to the right and one to the left. These are worth, if you essentially time and patience. It's a combination of sharp and blunt dissection this far out. They are densely adherent. They are designed to adhere to the valves. There's a very sclerotic reaction around them, and the rest of the valve is quite thickened around it. But again, if you take your time, if you break the clasp, or if you can unclip the clasp, you can almost always dissect these off. What I'm trying to do is to really preserve the anterior leaflet. It's going to be much harder to fix that if I lose the margin in the cords. But I'm going to convert the posterior leaflet to, again, a straightforward triangular resection, so I don't have to waste too much time digging the clip off of the posterior leaflet, where it was obviously still prolapsing. My view is to, a bit like endocarditis, get the clips off, preserving as much normal leaflet as I can, and then take a look at what's left, and then reconstruct it. And this is about 45 minutes worth of work just to get each clip off without damaging too much of the leaflets. And I kind of just remind myself, if I can debride an aortic valve, I can probably get these clips off with a little bit of time and patience. Then essentially, looking at what's left after all of the clips are out, you've essentially got a defect in the posterior leaflet, which is very straightforward, and then that defect in the anterior leaflet. And again, because I've managed to secure most of the anterior leaflet, I'm keeping this because it's a normal height cord. That's going to be a caudal transfer to the anterior leaflet. It's a nice height if I need to resupport it. This is a straightforward closure of a triangular resection again. And then this was a very limited triangular resection, so where it's, again, less than a quarter of the free margin, you should be able to close it without causing problems and replace those ruptured cords with that transfer. The patients often need adjunctive pathology treated. Here's a maze, the last lesion of a maze. While I'm doing the saline test, closure line looks good. That's the left atrial appendage closure. And the post-echo, I think it was trace MR, and no gradient. So lastly, very briefly, this is what they look like about 3 months out, much easier to get off. You can kind of peel them off, and that's my very good colleague, 6 years out of practice, doing a robotic removal and re-repair of a clip in a patient. Thank you very much.
38-year-old. Thank you, Joe. So, Michael, I don't know about you, but I have about